Good evening. Today we'll be discussing the NEET SS 2025 surgical group urology part. The first question is, following an RTA, a patient sustained injury with the blood at the meatus, unable to void urine. What is the best investigation of choice? So here the clinical scenario indicates an urethral injury. This is a paragraph from Schwartz. The clinical hallmark of an urethral injury is a blood at the meatus. So a RUG should be done when this clinical sign is present to diagnose an injury. So here the answer will be retrograde urethrogram. The second question is, following RTA, patient had the following injury. What is the next best step? Here in retrograde urethrogram image was shown with the leak of the dye indicating urethral injury. This is a paragraph from Sabiston. Here they shown, if it is a penetrating injury, we have to treat it immediately unless the patient is unstable. In all other injuries, anterior and posterior should be managed with SPC rather than instrumentation of the traumatized urethra with the risk of further injury. Though in Bailey there was a single line showing that we can give an attempt of Foley's, but according to Sabiston, this will be the answer rather than blind insertion of Foley's. The third question is, what is the best treatment for the following condition? A retrograde urethrogram was shown, which was showing a long filling defect, which indicates an urethral injury of long segment. So this is a paragraph from Bailey. In case of an traumatic strictures, anastomotic urethroplasty is done. But in case of non-traumatic and long strictures, augmentation urethroplasty is done using a patch, and the usual choice of patch graft for augmentation is the buccal mucosa. So the answer will be the repair with the buccal mucosal graft. Next question, a 65-year-old female presents with a cherry red lesion at the urethral opening with difficulty in urination which bleeds occasionally. What is the treatment here? Again, this is a paragraph from Bailey and Love. They gave here what is a caruncle. So this is usually seen in elderly women. It presents of soft raspberry-like mass about the size of a pea. It is nothing but the prolapsed urethral mucosa at the 6 o'clock position. Occasionally there will be bleeding also. If required, it is treated by excision and diathermic coagulation of the base of the stalk. So in this case, she had a difficulty in urination and bleeding occasionally. So the treatment of choice will be excision and diathermy. The next question is a very straightforward question. A child presents with bilateral hydrourethral necrosis with distended bladder, and this voiding cystourethrogram was shown, which typically shows the keyhole picture. So the diagnosis will be posterior urethral valve. For the same question with a similar diagram, and another question was asked, what is the treatment for this condition? The treatment is usually endoscopic ablation. So the initial treatment, whenever a child comes, we have to do catheterization to drain the urine and decompress the bladder and the upper urethral tract. But the definitive treatment will be the endoscopic ablation of the valves. The seventh question, following road traffic accident, patient is hemodynamically unstable who sustained a renal injury. What is the incision of the choice? In any case of when the patient is hemodynamically unstable, generally we go for a midline incision. But here is a statement which is given from the Sabiston. Here, urologists are typically trained to approach the injured kidney anteriorly through a midline incision and to obtain vascular control of the renal vessels to avoid any severe renal bleeding which may necessitate an urgent nephrectomy. So the answer is the midline incision. The next question, during pelvic surgery, there was an iatrogenic injury to the ureter was noted 3 centimeters above the VUJ. What is the treatment of choice? This is a paragraph from Sabiston. Here he has said that any incisions in the upper ureter are generally treated with closed perpendicular to the axis with a spatulated tension-free anastomosis. In the case of distal ureter, they are often require reimplantation into the bladder. So the answer here becomes ureteroneocystostomy. Primary repair is for upper ureter injuries. Next question. A middle-aged man was diagnosed with renal cell carcinoma of size 3 cm without breaching the capsule. So what is the treatment of choice? This is a paragraph from the Bailey and Love. They clearly showed even though radical is the gold standard treatment for localized disease, recently due to the increase in incidental detection of small renal cell carcinomas less than 4 cm, a more nephron sparing surgery is being performed. Therefore, partial nephrectomy should be the treatment of choice in such tumors. So in this case, as it is less than 4 cm, the choice will be the partial nephrectomy. The last question, what is the preferred regimen of chemotherapy for stage 2 non-semitomatous germ cell tumors? Again, this is a paragraph from Bailey and Love. Here they have said for stages 2 and 3, the preferred chemotherapy regimen is 3 cycles of bleomycin, etoposide and cisplatin, or 4 cycles of etoposide and cisplatin. These are being preferred now. So the answer will be bleomycin, etoposide and cisplatin. Thank you.